Hi, Monnie.
Hi, Neghae. How are you?
I'm all right. How are you?
I'm doing well, thank you.
And welcome back to another episode of the Nephro-Logic podcast.
I am Monnie Wasse. I'm an interventional nephrologist in Chicago.
And I'm Neghae Mawla, an interventional nephrologist out of Dallas.
So what's our topic today, Neghae?
Today, let's talk to our surgeons. You and I have a lot of surgeons that we interact with, that we rely on, and I think I have some messages for them. The surgeons here are good about interchange of ideas, of thoughts, and of co-managing patients. So they're perfectly fine with them doing the surgical components and me doing the endovascular components. And I think there's a lot of things that my surgeons know that I like to make an endovascular procedure easier.
Yeah.
And I want to share that with kind of all the other surgeons that are out there, because they may or may not be thinking about these kinds of things. It's kind of a Dear Surgeons episode.
Excellent. I'm ready. We probably have several similar things that we'd like to convey to the surgeons. And they're small, nuanced things, but they can make it a lot easier to maintain these because we get the maintenance phase, they get the creation phase largely.
And I think it's exactly that. How do you kind of tweak a surgical component or the surgical side of it just to help the maintenance side of it down the line? All right, what's one of yours? Go for it.
My big one, AV graft tunneling.
Too deep?
I am dying when I see an AV graft that is tunneled too deep. AV graft tunneling is an art, and please learn it, because when you see a graft that's tunneled too deep, I'm serious when I say that I've seen ones that are 9, 10, 11, 12 millimeters deep. You just have to scratch your head and say, what happened?
How?
A lot of times these are upper arm, but sometimes they're not. There's some hostile axillas, but I'm not talking about hostile axillas. I'm talking about the area with which two needles are supposed to go into the axis. And you literally can't even feel the graft because it's so deep. And this was clearly done by somebody who did not receive proper training and what it takes to actually be able to utilize the graft at the dialysis unit. There's a disconnect there.
So how superficial do you like to keep your graft?
So I think what's very important to remember is that when we look at through ultrasound, we look at the top of the graft and everybody says, oh, the top of the graft looks really superficial. It's only, 6 millimeters deep. But the needle actually has to get down to the middle of the graft. It has to get to the intraluminal space. And oftentimes that can be another millimeter and a half, depending on the diameter of the graft that you use. So I really like the top of the graft when I'm looking at it through ultrasound to be around 3 millimeters or no more. Sometimes it's even more helpful to be superficial, but you should be able to easily palpate that graft in the cannulation segment and know exactly where that needle is going to go. And there should be a sufficient length. That's my number 2, sufficient length on that graft so that there's enough site for needle rotation. How about you with regard to depth? That's a huge one for me.
I'm not going to expect anybody to sit there and measure a depth as you tunnel. For me, it's you should be able to see it and you should be able to grab the sides of it comfortably in order to hold it. For me, when I needle it, I'm not necessarily grabbing the side of the axis to put the needle in, but I know a lot of dialysis staff, that's kind of the culture and how they're trained. You just want to grab the graft and then pop the needle in. And so it should be easy to palpate, like you said, but I also expect if you can see it, then you can get it kind of thing.
I agree.
You're absolutely right. If you tunnel it and immediately, as soon as you tunnel it, you can't see where you put it, that's going to be a problem. And it is right in that cannulation zone.
Yeah. And my issue too is that you don't just send the patient out and say, just have them try it and see how it goes. Because what happens is they get a massive infiltration, and then the person who they complain to is the nephrologist. I'm the recipient of that. And the patient, understandably, is very skittish to be cannulated in the future. Even if you go back and fix it, they are very skittish if they've had a bad infiltration. Like, it's really worth spending some time getting this one right, because you've gone through the arterial anastomosis, the venous anastomosis, and then you blow it because it's too deep. That should be the most straightforward portion of the placement, in my view.
Most grafts that I use are 7 millimeters, or that I get, I should say, are 7 millimeter grafts. And so that would be 3.5 millimeters to the center. So to put it 3 millimeters from the skin surface, you've got your 6 millimeter depth for your needle tip.
Yeah.
So it has to be pretty superficial.
It does. And for where I am, we have primarily 6 millimeter diameter grafts. And so there's a lot of 4 to 6 tapers that are used. And just so you know, there's no data to support the idea that a 4 to 6 taper actually reduces the incidence of distal ischemia. So don't think that's what you're achieving when you put those in. Sometimes people use them simply because of a diametric mismatch. If they use something bigger that they're connecting the inflow to, because they've got a relatively small artery, but you're not going to get a reduction in, there's no data support the idea that you're going to get a reduction in distal ischemia because you do that.
Correct. And I think a lot of people here use we have a 4/7 taper, I thought, but I think it's just because the artery is kind of on that 3 to 4 millimeter size. They just go for the smaller there. Sometimes when I angioplasty, that means I got to pull out a second balloon to angioplasty the arterial anastomosis, but I can't do it all in one balloon.
Right.
So, okay. So graft depth is big. Graft length, how much length do you need for your needles?
Okay. So the key thing to remember is that a standard size length of needle in the dialysis unit, because we're coming at you with pragmatic information, is 1 inch. And generally, you want to ensure that there's at least 2 inches separation of the tips of the needles from each other to reduce recirculation. So if you think about what you need in a patient who's coming in on Monday, Wednesday, and Friday, and we need needle rotation, these are 15 gauge, 16 gauge needles commonly. I like to have at least 6 to 7 inches of cannulatable segment of that AV access, because in my view, that supplies enough room for sufficient needle rotation, where you're not going to immediately start to see aneurysm development in a fistula or pseudoaneurysm development in an AV graft. How about, what's your preference?
That's exactly what I was going to say. 6 inches is kind of my rule of thumb.
Yeah.
And again, that's not something I typically have problems with, but also I've got a lot of surgeons that know what I like and will kind of cater things to help me. But for everybody else to keep in mind, I think 6 or 7. I've seen some really small forearm loops. I've seen some really small thigh loops, and they become difficult to cannulate not only at the center, they also become difficult to put a 4-inch sheath into to do a declot.
Well, it's not even that. If that, I don't think there aren't a lot of surgeons we work with that want to continue to see the patient over and over for the same thing. So this is one of those that if you don't give enough cannulation length and kind of do it right, ideally that measure twice, cut once kind of thing, that patient's going to be back because their cannulation segment is going to wear down. And that's what will happen. And it's not uncommon to have to then go back and replace these within 8 to 12 months. We have patients, and you do too, I'm sure, that have their AV grafts for years. And they work really well, but that relies on there being enough cannulation zone to rotate needles.
As far as your venous anastomosis, arterial anastomosis, any preferences that you have?
I do have preferences. So for those of you interested in this topic, there have been a lot of devices that have come out, and there's been a lot of work primarily through Prabir Roy Chowdhury's lab and lots of fluid computational designs and studies that show what the optimal angle is for a dialysis access, both at the fistulas at the anastomotic site, and then for AV grafts at the venous anastomotic site, which is commonly where stenosis occurs. It is not a right angle. I can tell you that. We see lots of right angles where it's like a T-bone with the graft coming into the vein. You're getting your wire. It's practically actually kinking in order to get it up into the vein to do an angioplasty. And then when you try and stent those, invariably they require a lot of upkeep. Even those stents don't do that well there because they just have an anatomic curve in them that just doesn't work well for sufficient flow out of the access. So my preference is just taking into account the fact that you need to have an angle specifically around AV grafts going into the vein. It cannot be a right angle. It needs to be, I'd say, around 40, 45, because then you actually get smooth flow. And when we have to go back in and either do an angioplasty or a declot, it is much easier to do that and is much easier to maintain that access. So avoid the right angles, please.
So there is literature to say that right angles do not do as well as an uptick kind of thing?
There's a lot of data. There's a lot of data that was done in the mid 2000s, 2010, 2015. And if you're interested in this, Prabir Roy Chowdhury has done a lot of this work, but there are other authors that have published on this. And it's computational fluid dynamics looking at optimal angles for AV access, taking into account viscosity and all of the factors. And a right angle is not what we want for anything. It makes sense, right? It promotes turbulence.
Right.
So you end up with entemal hyperplastic development at that site. And it's just, it might be easy for the surgeon to sew in, but it is in no way optimal for the patient.
What else would you say to new access surgeons that are picking up a dialysis practice straight out of fellowship that may not have gotten that much in training?
Come to the dialysis unit. Visit the dialysis unit. And if you don't want to go to a freestanding dialysis unit, go to the one that's in your hospital and pop into the inpatient dialysis unit, go in there and watch them actually cannulate and access and see how it's done, what the needle length is, what the angle is that the dialysis nurses or technicians use. And you get a sense as to what sufficient needle rotation looks like and what insufficient needle rotation looks like. Because you'll know then what we're talking about around having a sufficient length and superficiality with the access. There's nothing more helpful in my view than going and seeing where your product you created is now going to be used. Because I would want that information because that's where things can go awry. And lots of people are asking themselves, why can't they cannulate this? Go to the unit. You can see why they can't cannulate it.
Or come spend a day with you and me.
Or spend a day with us. Yeah, spend a day with your friendly interventional nephrologist in your community. They'll be happy to have you see what they do. Absolutely.
And I have had surgeons come and spend a day with me and say, okay, wow, I learned a lot this day.
Yeah. Well, it's the same reason I go into the OR with them because I want to know what they do. I mean, it's not just one way. I like to go in the operating room and see how they're doing things. I've done this at all of the institutions I've been at with the surgeons I work with, and it's really informative. And then questions can be answered about, well, how long should I make this graft? Or what do you think about this elliptical curve on an upper arm AV graft as opposed to making it too medial in the arm? And then we can have a conversation about it so we can learn from each other. So it's great. It's truly beneficial collegiality for the patient's benefit.
I was just going to ask you about location-wise as the next question, but upper arm grafts or even a transposed basilic fistula, where do you really want it on the anterior, lateral, medial surface of the arm? What's the preference there for the dialysis centers?
They like it over the bicep. They like it transposed over the bicep because the patient is not oriented in such a fashion that their arm is everted during dialysis. Their arm is in a position as though you were shaking the patient's hand. So that means that the access actually has to be over the bicep if it's an upper arm AV graft or if it's a brachial basilic transposition. It can't be too medial. If you make it too medial, if there's a back wall injury, it's not uncommon for that 15 gauge needle to go and stick the inflow artery. And it's a bad day for everybody when that happens because the patient's arm blows up. If their blood pressure is high, they can bleed into their arm. It can be an absolute disaster. So getting that cannulation segment away from the underlying artery is really, really critically important and part of the consideration of doing the transposition. Right. How about you? What are your thoughts about where to position it?
When you meet a patient, look at the position they're comfortable in that office chair that first time. And that's basically their default position. And that's how they want to sit at dialysis. So put the graft where they can sit like that, and then everybody's happy. Patients are happy. They're not having to sit in an awkward position. Where are your arms on your lap? Are your arms on the armrest? Where is it that you're comfortable? And then that's how we're going to position the graft so that you can stay in your natural default.
I like Steve Homan's approach. He's a vascular surgeon that many of us know who's in Dallas, and he has the approach of marking the arm with the patient, as I mentioned, in a handshake position. So if you're shaking their hand, it's placing the graft, it's effectively over the bicep, but marking it well in advance before the patient's on the table, instead of the splayed out arm off to the side and then putting the graft in and being surprised that it's too medial when they come off of your table. So right. I think that's a really helpful approach.
Yes. And I think marking before you put them on the table is always the right thing to do.
Always.
Whether that's on the arm, whether that's on the abdomen for PD and exit sites, even for perm cath, I used to mark before kind of where my exit site was anticipating. All of these are based off natural position, not on the table position.
I think the other thing to realize, I have several shifts of dialysis patients now, and when you place that needle too medially and when they're comfortable, they're sitting on dialysis for 3.5 or 4 hours, invariably what happens is that their arm turns in. And so when I walk by and I see that the venous needle pressures are really high, oftentimes it's not because there's a problem with the access. It's because there's some element of needle disruption or it's been shifted over to the wall of the access because the access is so medial and now the patient has actually shifted their arm inward. So really getting that off of the inner portion of the arm is really important. We end up getting referrals for reasons because of that. And oftentimes we don't find any problem, and it simply has to do with the position of the access itself.
Correct.
Yeah.
Any problems going to lateral with your tunnels?
Well, I understand why people do that. I don't tend to see that too much, but what you commonly see is if somebody's doing a brachial basilic graft, for example, they will, or a brachial axillary, they'll utilize everything from the antecubital space all the way up to the axilla, and they swing it wide. So that makes it challenging to put an intraposition graft in. And I like to always think about what's the second and the third and the fourth access that this patient is going to have. And so there's a sweet spot when you're putting that access in and keeping the anastomotic, the venous anastomotic segment relatively distal enough so that when the time comes and you need a new access, you can actually swing it up slightly more proximal to the axillary vein. And just thinking about, like, if this goes down, what am I going to do? If this goes down, what am I going to do? Yeah. I always think about that. And that informs whether I stent the vein or whether I call my surgeon and say, do you want me to stent this or do you want to do an interposition? I think that is a very helpful approach, is that when you're going in and putting in your access, think about what the next access on that same exact arm is going to be. Because
how do we revise this one? How do we modify
correct.
This one? Not how do we start all over again?
Not how do we begin again? Yeah. And stay on the messed up side. That's what I always say. Exhaust the messed up side before you go to the other arm, if possible.
Yes. I had one patient tell me it was a revision. And so they started on top of the bicep and the next one was more lateral. And they actually said, oh, I wish I would have had this one first because the depigmentation that he had was not as visible being on the outside of the arm, at least to him. And so it was I like how the really laterally tunneled graft, the wear and tear of it is not as obvious to me as it was right on top of the front.
Interesting.
It's a perspective thing. I share that, not necessarily thinking that we should go laterally, but it's just everybody brings a different perspective. And this was a patient perspective that I had not even considered before or heard before.
I think one other approach, as you were talking about the positioning, that reminded me is that for patients that have bigger arms, I mean, I was in Atlanta for 10 years. We had a similar patient population. Patients tend to be a little thinner here in Chicago than they were where I was before. But for patients that have big upper arms, and, there's always a discussion with the surgeon about, I always hear a lot about the hostile axilla. That is such a thing. But getting in there and being concerned about incisional healing and so on, that is where I think it's very helpful to do more of an elliptical positioning of the graft as opposed to, sorry, I'm using my arm, I'm trying to look like I have a good bicep. But instead of actually going up like this, it's actually taking the arm and making an ellipse so that it's almost like a C, like this, as opposed to a big curve like this. And so you're actually going off to the side. So you're using the space that you're using for the venous and the arterial connections don't take as much room on the arm. So therefore, you're avoiding the hostile axilla issue, and you're going and utilizing an artery that's lower and more distal. And that's simply by positioning the graft so it actually comes off to the side like this, as opposed to like this.
Going up that way. So your venous anastomosis is lower on the arm? Is that what you're saying?
Yeah, the venous anastomosis is lower on the arm, and the arterial anastomosis is about here. But if you swing the graft out laterally, you still get plenty of cannulation segment. You're in a thinner area because you have control over the graft, but you leave a lot of room for subsequent accesses on that arm. And as long as that patient isn't somebody who is going to be at risk for distal ischemia, where you would ask yourself, do I want to use a more proximal artery? This works really, really well because it provides enough cannulation segment. It gets the cannulation segment away from the inflow artery, and it still preserves enough vascular anatomy proximally for you to be able to utilize it for subsequent dialysis access.
I've not seen a lot of that here.
Yeah, I like that approach a lot. I've been asking my surgeons for that now recently. It helps.
Okay, mentioning axilla, what about this notion of prior lymph node dissections and whether you can or cannot put an access in?
There's no data to support the avoidance of dialysis access in the setting of a lymph node dissection. And especially now with the modern day lymph node dissection, where they tend to be far less radical than they were, I think, in the 70s and the 80s. So that question comes up periodically in patients who've had breast cancer, for example. We want to avoid putting an access in that arm, and then you map them and everything looks beautiful. There's just no reason to avoid that in my view. How about you?
Sometimes that notion is not a surgical notion. It's more of a patient perspective. They've been taught that, just like we teach them vessel preservation, no more blood pressures in that arm. Some of these patients are very good about wanting to preserve that. And so it's just a matter of educating them and discussing with them, saying that's older literature.
I agree.
But I think a lot of people have shifted away from that fear as well. So I think it's more of an intellectual fear than a real one.
I agree with you.
One of my pet peeves is when a fistula gets converted to a graft.
I know what you're going to say. It's my pet peeve too.
We've posted this on Twitter, right?
I know.
In all of this is, where do you make the arterial connection on your PTFE segment, and how much of a stump do you use, and do you Do you connect it right to the original fistula, or do you just go to a brachial artery? And I would say, if it's not too much work, just go to a brachial artery and make a true proper arterial anastomosis with your PTFE. If you leave anything longer than 2 centimeters of a fistula stump, even 2 centimeters is a lot, that part dilates out. And when the circuit goes down and that part fills up with thrombus, it is an endovascular nightmare to try to do a declot on that patient. The rest of it will be just fine and it'll be quick. But I have spent sometimes upwards of an hour trying to get that fistula stump cleared. And the longer the stump, the bigger the problem.
I beg of you, don't use the stump. Don't use the stump, because you're absolutely right. Oftentimes we'll see them from using the proximal radial artery below the antecubital space. And then they'll actually attach an interposition graft, a good 8-9 centimeters proximal to the anastomosis of a fistula. So you've got a stump that's this long.
That's long.
Crosses the elbow. And so when you're going to try and declot that, it's always dilated because there's a diametric mismatch between the fistula and the graft. So it balloons out, contains a ton of clot, and you have to take so much care to not actually send clot as you're doing this declot down into the artery as you're trying to dig it out. It's challenging. Do a new anastomosis. It's just so much easier to maintain these, because invariably the problem spot is always at the vein graft anastomosis.
Yes.
Always.
Yes, it is.
Always.
The graft to vein, the outflow is easy like always.
Outflow is easy.
But that inflow will turn a 10-minute declot into an hour plus.
An hour and a half. I think I've spent 2 hours on one before.
And it's always that, it's just a little bit left. We're 90% there. If I can just get that last little piece, because if you don't, it will come and plug up.
It'll plug up the graft.
It'll plug up that little piece of graft inflow, and the whole thing will go down again. So,
exactly right.
So please, please, please.
We beg of you, please don't tie it to a stump. Start with a fresh anastomosis.
When you're doing a revision, converting a fistula to a graft, just do a fresh arterial anastomosis.
Anastomosis.
Yes.
For the love of God, please.
Yes, trust me, every interventionalist, nephrologist, and radiologist will thank you for that.
Yeah, they will thank you. You'll be their favorite person after that. I think that's a good one to end on.
I think so.
All right, I've enjoyed talking to you. We're going to come up with some other topics in the future, and we'll have some special guests as well. I think our next efforts will be to corral some of our surgical colleagues to talking about specific things around anastomotic size and flow and inflow-outflow mismatch, and some really pertinent topics.
Correct, because we've spent the last 2 episodes talking to our surgeons, so now I think it's time to give them a chance to rebut some of the things we've said to them and hear from them. We are looking forward to the next one. If you have not, please like and subscribe.
Excellent. Okay. See you next time, Neghae.
All right. Bye, Monnie. Bye.